what I want to do now is just to give you an idea of where to find some information about this stuff, and how to review. Once again, I showed you this imaging software that you can look at the brain, and it's going to be labeled. Let's see here. You can see different. This is the MRI imaging, and you can move it one way or the other. You can hopefully see the think about the three-dimensional nature of the brain, and the fact that in some areas, if you're taking a slice of the brain, sometimes you're going to be seeing the ventricles, like for instance the lateral ventricles, like I show you here in this white area right here where my pointer is. And then if you move a little bit more sagittally, you're going to see another structure more prominently. Those lateral ventricles then go away and are much reduced in prominence. And then this corpus callosum is present. So here is the corpus callosum, and that's a major point of orientation in the brain, right, and on that sagittal section. So that's one thing that we've already talked about. So I want to bring you back to the things that I've shown you for Unit 5. So in terms of the way that I've organized this class right here, this structure, we're going to be talking about, so we've already talked about chapter 13 rather, which is the brain. The next unit, the next week, we're going to be talking about two chapters, chapters 14 and 16. These other files right here, there's the vocabulary section, there's the ANS and SNS chapter 15 and 16, there's the brain lecture. Those are from the old textbook. So if you wanted to see different views of this, different information, or the same information presented differently, that's one thing. That's one thing to do. So another thing I want to show you is this structure right here. Let's see. There's a bunch of videos that I can show you. So we're not going to watch all of them, but I want to watch a couple. So the first thing is the distinction between the differences between the meninges in the context of the spinal cord versus
Science, where I simplistically explain neuroscience topics in 2 minutes or less. In this installment, I will discuss the meninges. The term meninges comes from the Greek for membrane and refers to 3 membranes that surround the brain and the spinal cord: the dura mater, the arachnoid mater, and the pia mater. The meninges protect and provide structural support for the brain, as well as contain cerebrospinal fluid. The outermost layer of the meninges is the dura mater, which literally means hard mother. This thick and tough layer adheres to the skull on one side and the arachnoid mater on the other side. The dura provides the brain and spinal cord with an extra protective layer, attaches the brain to the skull and the spinal cord to the vertebral column to keep them from being jostled around, and provides a system of venous drainage through which blood can leave the brain. The arachnoid mater gets its name because it has the consistency and appearance of a cobweb. It is much less substantial than the dura. Strands of connective tissue called arachnoid trabeculi stretch between the arachnoid and pia mater. These help to suspend the brain in place. Between the arachnoid and pia mater, there is also an area known as the subarachnoid space, which is filled with cerebrospinal fluid. The pia mater is a thin layer that closely follows the contours of the brain. It forms a tight membrane around the brain and spinal cord, acting as an additional barrier and aiding in the secretion and containment of cerebrospinal fluid. Blood vessels are held against the pia mater by connective tissue before they penetrate the brain. There is a space between the dura of the spinal cord and the bone of the vertebral column known as the epidural space. Analgesics and anesthesia are sometimes administered here. Also, the dura and arachnoid mater extend several vertebrae below the end of the spinal cord, creating a cerebrospinal fluid-filled area called the lumbar cistern, where there is no spinal cord present. Cerebrospinal fluid can be withdrawn from here because a needle can be inserted with little risk of damaging the spinal cord. Thus, the lumbar cistern is the site where cerebrospinal fluid is aspirated in a lumbar puncture, also known as a spinal tap. This is done, for example, to diagnose meningitis, a potentially life-threatening inflammation of the meninges.
So one question that I have asked in the past is where in the brain will you find the epidural space? And the answer is you won't. Right? Why won't you find the epidural space? Because the dura mater is fused to the skull. So what spaces in the skull are you looking at as far as where cerebrospinal fluid is found? It's going to be the subarachnoid space. What other material is found associated with the brain that's fluid in nature, in addition to plasma and cerebrospinal fluid? And that would be blood found in the sinuses, in the blood sinuses. So there's that. Again, this is all associated with the, it's all open for you. Let me see here. Let me see here. There's another thing that people confuse. Midbrain.
Science, where I explain neuroscience topics in 2 minutes or less. In this installment, I will discuss the midbrain. The midbrain is one of the 3 divisions of the brainstem. At the level of the midbrain, the 4th ventricle has narrowed to form the cerebral aqueduct, which connects the 3rd and 4th ventricles. The region of the midbrain behind the cerebral aqueduct is called the tectum. The area in front of the cerebral aqueduct is called the tegmentum. The anterolateral portion is made up of 2 structures called the basis pedunculi. The tectum primarily consists of the superior and inferior colliculi, clusters of neurons that together form 4 bumps on the posterior surface of the brainstem. The superior colliculi are thought to be involved with directing behavioral responses towards stimuli in the environment, while the inferior colliculi are known for their role in auditory processing. The tegmentum contains a variety of ascending and descending tracts, like the medial lemniscus and anterolateral tracts. It also contains fibers from the superior cerebellar peduncles, the main output pathway of the cerebellum, and the red nucleus, a nucleus thought to play a role in motor coordination. The tegmentum contains nuclei for cranial.
So when you're talking about these tracks right here for this quiz, these tracks won't necessarily be discussed, just in general, right? What does a track do and things like that. But when we get to the next unit or the next discussion next week, we're going to start talking about things like the spinothalamic tract and spinocerebellar tract, and those tracts will be really we'll get into greater detail about.
4, as well as neurons that are part of the raphe nuclei, the major serotonin-producing neurons in the brain, and the ventral tegmental area, one of the largest collections of dopamine-producing neurons in the brain. The basis pedunculi include the crura cerebri, 2 large bundles of axons that contain fibers from motor pathways like the corticospinal and corticobulbar tracts. The basis pedunculi also include the substantia nigra, which is another major dopamine-producing structure in the brain. Finally, the area surrounding the cerebral aqueduct is called the periaqueductal gray. The periaqueductal gray is known for its role in pain inhibition.
Remember, to the terminology that I use in the lecture, if it overlaps with these videos, then you should definitely focus on that. Any terminology that is used in the videos that I haven't used, it's not going to be perfect, but you can guess that the likelihood that I use those in questions is going to be very low. One more that I want to look at here, and then so we just talked about the cranial nerves.
The vagus nerve is an extremely long nerve that travels from the brainstem to the colon and has a long list of functions. It carries sensory information about pain, touch, and temperature from the throat, parts of the inner and outer ear, and the meninges near the back of the head. It plays a very minor role in taste. It also receives sensory information from internal organs in the neck, chest, and abdomen, like the esophagus, heart, and digestive tract. And it carries sensory information from both baroreceptors in the aorta that detect changes in blood pressure and chemoreceptors in the aorta that sense oxygen levels.
These receptors are 2 things we're going to talk about next week. These chemoreceptors, the name chemo means something, right? Chemochemical. Baro meaning physical stretch or stretch receptors. They are very important, and we'll talk about those later on next week.
The vagus nerve controls the movement of a number of muscles in the pharynx, soft palate, and larynx, as well as one muscle in the tongue, to play a critical role in the control of speaking and swallowing. It is also the main parasympathetic nerve of the body, providing parasympathetic innervation to organs throughout the neck, thorax, and abdomen, contributing to a variety of functions such as the slowing of heart rate. There are several nuclei in the medulla associated with the vagus nerve and the different types of information it carries. Information about touch, pain, and temperature travels to the spinal trigeminal nucleus. Sensory information from internal organs or visceral sensory information travels to the solitary nucleus. Motor signals originate in the nucleus ambiguus. Parasympathetic fibers originate primarily in the dorsal vagal motor nucleus, while some parasympathetic fibers that travel to the heart begin in the nucleus ambiguus. Symptoms of vagus nerve damage may include hoarseness of the voice, difficulty swallowing, and a deficient gag reflex. The uvula may deviate away from the side where the damage has occurred. Because the nerve supplies a number of organs, however, damage can result in many other symptoms as well, like abnormalities in heart rate or gastrointestinal problems.
So if there's damage to the vagus nerve, there's going to be there's not just that is going to be impacting it. It's going to be a lot more than that because the vagus nerve impacts so much. It mentioned the parasympathetic system. The vagus nerve is responsible for about 75% of the parasympathetic nervous system in the abdominal pelvic region. And one last video here. Let me show you this.
We knew that the tumor directly abutted some areas that were very important to her speech centers. So I had decided that on this occasion we needed to take a different approach.
A craniotomy is a surgical procedure where the cranium, the skull, is opened. An awake craniotomy means that the patient is awake at some point during the operation, so you can test language function during the operation.
The object this time was to establish a new path.
So just so we're clear here, this is an actual operation. This happens in a number of different sort of situations here, but this is an actual operation. The patient is going to be put under anesthesia. They're going to be put out. They're going to start the operation, then they're going to wake her up, and then they're going to start asking her questions as they're operating on her brain. So they're going into her brain, they're removing structures from the brain, they're targeting this cancerous tissue, and it doesn't hurt. Why doesn't it hurt? The brain doesn't have any sensory structures. The brain doesn't have any pain senses. The brain, so superficial to it, it does. But the brain itself is full of neurons, but none of those neurons sense pain. So I think it's really interesting, and so I just wanted to sort of talk about that.
And then watch during that resection that we didn't interrupt any pathways that were important in her speech.
Tiffany, open your eyes. Yes, sweetie.
Can you see how many fingers I have up? How many? Good. We needed to keep her talking pretty much throughout the 2 hours that she was involved with the surgery. We wanted to make sure that the areas being removed were not directly impacting upon language, and there's no better way of doing that than actually having the patient awake and speaking at the time.
So what we do is we stimulate various areas of the brain in the region of interest, and we test whether the patient can speak, can read words, and do other language tests.
Ready? 3, 2, 1.
A little stuttering. 15 milliamps.
3, 2, 1. Very good. You're getting better and better at this.
We've had now 3 pictures, 3 words with some slight hesitation on 2 of the words and then like stuttering on 1 of the pictures. Are you satisfied or do you want any more?
Here, I think
This is baseline.
she's doing better than the previous baseline.
Okay, so non-language, that was electrode position number 5.
And then once we've made the commitment, okay, here is an area that we think is safe to enter our brain, we continue to map the area if we're concerned, and also they're continuing to test her ability to speak as I'm getting closer and closer to the actual tumor.
William will be late. William will be late. I am trying not to sleep.
As weird as it might sound, I liked it. I like that I can be awake while he's taking it out. And I know it's important that I am awake while he's taking it out because he can, he'll be able to test me and my speech to, you know, so while he's taking it out, if I mess up with my speech, he knows that that area he should not touch. So I know it was really helpful to do that, and it was different for me. And you know, not everybody gets to say that they were awake during a brain surgery.
I'm proud of it. It's allowed. Okay, so give a really nice dream. We'll see you when you get back.
I'm so much better with my speech and everything. Everything's good. I'm healing really quickly.
I'm quite optimistic that she's going to be able to live her life and to accomplish her dreams now.
I always wanted to work at Montefiore. I know it's a very reputable hospital. I've been to different hospitals, and this is like the best one in their care, the way they treat their patients. I love it, and I wanted to be part of that.
Using the team that we have here was absolutely critical. Without that team, we could not have accomplished what we did.
Tiffany was the most amazing language mapping that we have ever done in terms of how she was always so cheerful and really trying her best. Think about being in this environment in the operating room and knowing that somebody is taking out something from inside your brain. She was a wonderful patient, and wonderful patients help you to help them better.
So one of the things I want to,
Back in September, I had a seizure.
there's other examples of that, awake craniotomy. But one of the things that I wanted to just bring to your understanding is so that you notice that they provided 2 different types of stimuli. So the first was written words, and she had to read those words. So she had visual stimuli. So they're coming from the eyes, it's going to the brain, and then it's going to the sound production. So that there's that pathway. And then the other form of stimuli was they read a sentence to her, and so I'm trying to stay awake. Right? I'm trying not to fall asleep, I think is what she said. That is coming from a different pathway. And that pathway then, it ends up at the same place, producing language, but the pathway within the brain is different. And so what they're doing is they know where the tumor is. They're trying to get into the brain, get to the tumor, and then another thing that they did was they stimulated part of the brain, and you could see sometimes when she was saying words, affect pretty clearly, she was saying it, responding clearly, and other times when she was stuttering or mumbling her speech. So in that case, when you stimulate those nerves, that means that that's directly related to speech production, and you want to avoid those things, right? So hopefully this is trying to draw all of this together in terms of the brain and how it functions, or some of the ways how it functions. So are there any questions for me as far as what we're doing this week. Oh, wait a minute here. Let me show you once again. I've had several people asking me questions about the course and the schedule. So if you look on the right-hand side, right, this is the schedule right here. We're right there. We're done with the brain. Quiz on Monday, no lab this week. I'm gonna find out when Miss Bittinger can be at lab. The lab is going to be at it for a defined time. She can't be there for the whole day because she has other responsibilities. In addition, there's LT assignments that are due. I think that I'm done with, I don't remember if I'm done with all of the Unit 4 assignments. I'm gonna be finishing up, going back over the Unit 3 assignments, and then those will be finalized. Those Unit 5 assignments are coming due as well, and they're due, I think it's this Friday. They're gonna start coming due, and then next week there's LT assignments, and then we'll have the mini practical on the brain. And we're not going to, if there's any questions on the LT assignments, I think that there is 4 assignments that are live for you, one summary and 3 lessons. If there's a 5th assignment that has to do with sensory structures, I don't think that it should be visible to you. You don't need to do that because we don't have time to do that the way the semester works. So I'm not gonna, that's actually a lab, an experiment, and it's not something that we're gonna do this semester. So are there any questions for me? All right, so I will end class here and let you guys go. If you have any questions, you can come up to me, but refer to the Brightspace webpage, because this is the new schedule here. And this is the final schedule. Guys, 2 more weeks and then you're done. You don't have to listen to me ever again.
Unless